Hello friends, welcome to the show Talk with Your Doc. I am Dr. Prashant Jani, and with us today is Dr. Scott Cassie. He is a bariatric surgeon at Thunder Bay Regional Health Science Center. Bariatric surgery is one of the treatment for obesity. Obesity is increasing not only in America but all over the world, and there are many diseases associated with obesity like hypertension, diabetes, heart disease, and many others. Treatment of obesity involves diet, nutrition, exercise, as well as surgery. And bariatric surgery has very important role in the treatment of obesity. And Dr. Scott Cassie is going to guide us on various aspects of bariatric obesity treatment. Thank you, Dr. Cassie, for coming today for the show.
Thanks for having me.
Thank you. Please tell us about obesity and surgery.
Yeah, I think obesity, as you touched on, is a growing epidemic at this point, and really, although we know that there are some non-surgical methods of weight loss, from what we've seen over the years and a lot of research, we think that surgery is the one sustainable method of losing weight that we know remains long-term. And so, as far as we can tell nowadays, for at least a subset of the population who become morbidly obese, we think this is probably the most effective treatment in terms of losing weight and keeping it off down the road.
So, obesity, what percentage of people would need the surgical treatment?
That's very difficult to say. I mean, when we look at surgical candidates, it really comes down to what's known as the National Institutes of Health guidelines, and those are about 20 years old now. Mm-hmm. In terms of the proportion of the population who actually undergo surgery, if you look at the people who meet those criteria, which I think we'll touch on in a few minutes, really only about 1% of eligible or potentially eligible patients actually undergo surgery in North America every year. So it's actually a very small subset of the population. And so we like to try and get the word out because there's a lot of lack of knowledge and misunderstanding about bariatric surgery. Right. So we try to get the word out so that people are aware that this is an option for them, and their family doctors are aware that sometimes a referral to a bariatric surgeon may be an optimal therapy for these patients.
Right. So for one to get bariatric surgery for the treatment of obesity, what are the criteria?
Yeah, so if you look at those NIH guidelines, which are slowly being changed over the years, essentially we look at the BMI or the body mass index. And if a patient has a BMI of 40 or higher, automatically they're considered a potential candidate for surgery. If their BMI is 35 or higher and they have at least one obesity-related comorbidity, so for example, diabetes, hypertension, sleep apnea, the things you touched on earlier, those patients are also potential candidates. Now, when they look at those patients, obviously, they can't have any uncontrolled depression, uncontrolled psychosis. They can't have any binge eating disorders and no addictions to alcohol or drugs. Okay. And of course, they have to be medically stable to undergo an anesthetic that lasts a couple of hours. But outside of those criteria, any of those patients with BMI over 40 or 35 would be potential candidates.
So BMI of 40 means what is the weight range?
Exactly. So you look at their weight range, it depends on height. So everything with BMI is your body mass index really looks at your comparison of your height to your weight. So a typical patient is probably, if you're looking at pounds, at least about 250 pounds or up from there, but it really depends on the patient's height.
Right. So now, once one is selected for bariatric surgery, what are the options of surgery?
So now this has been something that's evolving over many years. There are a few that are now considered outdated, but if you look nowadays, there's essentially probably 4 procedures that are considered current. The first one that's probably the most well-known is gastric banding, where a little Teflon band is placed around the top of the stomach. That band has a little port that sits underneath the skin.
So it will reduce the opening of the stomach probably.
Exactly, and so you can inject that port, and there's a little balloon in the band, and as you inject the port, the balloon fills up and it causes some restriction around the top of the stomach and essentially creates a small pouch at the top of the stomach.
So you can't eat more probably then.
That's exactly right. Now that's something that's been around for probably at least 10 years now. It looked very favorable 10 years ago. I don't think the outcomes have been quite as favorable as we expected. And it's slowly, in my mind at least, being phased out. It is still being done in Canada, but a little bit less so now than it was years ago. The second option is something relatively radical known as a duodenal switch procedure. This is something, again, is a little bit historical but has made a real comeback, especially in the eastern provinces. And essentially it combines some trimming of the stomach into a long narrow tube and then a segment of bypass of the bowel. Now, it's very good for patients with what we call super obesity, so BMIs of like 60 and above. There are some risks with it because it's so radical in terms of how much the bowel is bypassed. Some patients become malnourished. There is a risk of chronic diarrhea and issues such as that, and so we typically reserve it for patients who fit that category of super obesity. Now, the two other procedures that are, and those are both offered here in Thunder Bay, are gastric bypass and sleeve gastrectomy. So with the gastric bypass, we essentially turn the stomach into a small pouch. And that pouch is supposed to be around 30 to 50 cc's in volume. We then pull the small bowel up, attach it to that pouch, and we reattach the bowel distally. So it works well because the patient gets full faster. They can only get in a restricted amount of calories. And what they do eat travels about 1 meter to 1.5 meters with very little to no absorption. And they get distal absorption from there. So it's a nice combination of a restrictive and a malabsorptive procedure. And the sleeve gastrectomy is relatively new. It's come up in the last 8 years as a standard.
I think that is the one commonly done nowadays.
It depends on where you go. Everything with bariatrics is quite geographical. In France, in the US, the sleeve is the #1 procedure.
Is done commonly.
In Canada, at least in Ontario, I would say bypass is by far still the #1 procedure. About 75 to 80% of procedures are gastric bypass, and sleeve is about 15 to 20%.
So what is the mechanism by which all these different surgeries work, and how do they reduce the weight?
Sure. So in terms of the mechanism by which they work, it's primarily due to restriction.
Diet restriction.
Exactly.
Intake.
So intake restriction. So we limit how much food can go in at once. We limit how many calories that patient's taking in, thereby they're going to lose weight. That being said, if you look at some of the procedures like bypass and duodenal switch, there is a malabsorptive component as well. So usually it's a bit of combination of some malabsorption. But when you look at the overall picture as to why these patients lose weight, there's probably some underlying features that we haven't quite figured out yet. Most of us believe that it really comes down to some hormonal changes. There's probably some changes in gut signaling hormones. And so we think that may be some of the underlying cause. And certainly after we do a sleeve gastrectomy, we know that some of the hormones responsible for hunger, namely ghrelin, are significantly reduced after the operation. So
your diet goes down and your appetite goes down probably.
Exactly, that's right. That's right.
So basically it might be reducing your stomach capacity and reducing those hormones and...
Exactly, yeah. There's an increase in, it's a whole science unto itself, but there's an increase in some hormones, a decrease in others, but the basic overall feature is, yes, malabsorption and restriction in calories.
So those patients who undergo surgery, are there any risk associated with it?
Yeah, definitely. So I think if you look, and this has been one of the criticisms historically, I think it was considered some of these operations were very high-risk procedures. And with the introduction of laparoscopy to surgery, where we do everything with a camera and usually 4 or 5 small incisions, typically those risks have been minimized over the last few years. But when you look at post-op complications, we usually divide it up into sort of the immediate post-op phase, that first week or two post-operatively, and then the more chronic phase. And so immediately post-operatively, when we consent patients in the office, we always tell them about the risk of an anesthetic, always a small risk of heart and lung complications. We talk about a risk of bleeding. There's about a 1% risk of a major bleed that would require another operation.
So there are complications associated with this obesity surgery probably?
For sure, yep.
Right? Maybe we can take a short break and we'll talk about the complications in the next part.
Sure, that sounds great.
Thank you. Please come back after the short break. Welcome back to the show, Talk with Your Doc, and today we have Dr. Scott Cassie with us, and we are talking about bariatric surgeries, which are one of the treatments for obesity. Dr. Cassie, you were talking about different surgical options, and how do one select different options among those 4 options you mentioned? Which one should go for?
Yeah, again, this is a bit of a geographical issue. Everything is provincially mandated, at least in Canada, and so it makes things a bit more difficult. I think typically, as I said, the gastric band is something that's being done privately nowadays, and I think it's slowly being phased out, and to be honest, it's not something that we recommend to any of our patients at this point. The duodenal switch, as I mentioned, more for super obesity and BMIs of 60 and higher, and so that subset of the population is someone that I generally encourage to seek.
Super obesity means too much, maybe 400, 500 pounds?
Yeah, so BMI of 60 is probably, in most individuals, is looking at well over 400 pounds,
400 pounds.
Again, depending on height, yes.
Okay.
And so that takes care of that subset of the population. And then with regards to sleeve and bypass, it really comes down to a few features. We know from the long-term data that bypass gives good weight loss. Patients can keep most of that off. We also know it's a very good therapy for things like diabetes, high cholesterol, and high blood pressure. Probably a little bit more effective than the sleeve.
Okay.
So in most cases, if a patient can have a bypass, we usually push them towards a bypass.
Okay.
That being said, the sleeve is still a good operation. The weight loss is slightly less than what we see at the bypass, and not quite as effective for things like diabetes, high cholesterol. So there's certain times where if a patient's had previous surgery and they have a lot of scar tissue and we can't safely do a bypass, in some cases if they have some inflammatory bowel disease or some sort of malabsorptive disease, if they have liver cirrhosis, or if they're dependent on anti-inflammatory medications, those are some of the scenarios where we generally recommend a sleeve gastrectomy instead.
So which one has low morbidity or mortality associated? Which one of those 4 surgeries is less risky?
To be honest, what I tell most of our patients, at least in the perioperative phase, the complication rates are essentially the same between most of those. We'll leave the band out of it for now. But if you talk about problems such as bleeding, problems such as wound infections, those are pretty infrequent, happen about 1% of the time. When we talk about problems like blood clots or pulmonary embolus, those occur in about 1% of patients as well, and that's pretty much across the board. The other concerns are leaks after surgery, which occur in about 1 to 2%. And if you look nowadays, the overall mortality of surgery, we used to quote about 1 in 200. Now it looks like it's probably closer to about 1 in 500 to 1 in 700. So it's still not without risk, but better than a few years ago for sure.
So once somebody gets the surgery done for the obesity, how long it takes him to lose the weight and how much weight one can lose?
Yeah, so most of our patients are losing weight before the operation. So in order to do the operation safely, we put them on a weight loss shake.
Okay.
The main reason for that is it actually helps to shrink the liver volume by up to 40%.
Okay.
And we're trying to get up to the top of the stomach to safely do the operation. If the liver's too large, we simply can't do it. So they usually are losing at least 15 to 20 pounds preoperatively in most cases.
With the diet and exercise.
Exactly, just with the shakes we give them and exercise up front. After the operation, the initial weight loss is usually quite rapid. But what I tell them in most cases, again, it's hard to quote numbers because it depends on their starting weight, but I think on average, after a gastric bypass, for example, we usually see them lose about 100, 150 pounds the first year.
1 year.
What we typically look at is their excess body weight, so the amount that they weigh compared to what their ideal body weight is.
Yes.
And if you look at that, we usually tell them they're going to lose about 50 to 70% of that excess body weight in the first year. And that's a pretty typical amount they see with most patients.
And then over the period of next few years, are they able to sustain that weight loss or they gain the weight back? How does that happen?
In general, they will lose weight for about 18 up to 24 months post-operatively. Usually they'll start to plateau at that phase. It definitely is a slow weight loss after that. A lot of patients will gain back a very small amount, a few percent. We do have some patients that will regain a large amount. And so I tell them what I was always taught during my training, that this is not a magic pill. This is essentially like pressing the reset button. So we'll take them back 20 years. We'll take off 100 to 150 pounds. Usually we'll get them off of some, if not all of their medications, and they get a fresh start. If they have poor behaviors, similar habits to what they had previously, they may regain the weight and maybe end up in the same boat they were in.
So does this surgery affects overall health of a person other than the weight loss, like other parameters of the health?
Sure, I think that's actually the biggest impact. So everyone talks about the numbers, but when you really look at it, the Swedish trials from about 10 years ago showed us that if you have an obese patient who undergoes an operation, regardless, they looked at a few different procedures, 10 to 15 years down the road, there is a significantly higher chance they would be alive if they had surgery than if they did not have surgery. So that was the biggest thing. And the reasons for that, as you've touched on, it's a good cure or improvement in diabetes. High blood pressure, high cholesterol all tend to improve.
They all
Sleep
go down.
apnea, exactly. So we see vast improvements in all those things. And for reasons that we don't understand, some of those improvements occur immediately. So if we have patients that come in on 1 or 2 oral medications for diabetes, within 48 hours when they go home from the hospital, they're usually off those medications completely, and they usually stay off of them. So it's an immediate effect for some of those medications.
So diabetes maybe get cured also probably.
Yeah, there's pretty good data that if we do a bypass and we follow these patients for a year afterwards, the chance that the diabetes will either be cured or significantly improved is about 80 to 90%.
And same with the heart disease and blood pressure.
Yeah, exactly. Those numbers aren't quite as favorable, but again, in terms of hypertension, we see about a 70-75% cure rate after a year. year. So the response is quite rapid, and it's quite profound.
So now, once one undergoes surgery, what is the change in the diet or the nutrition?
Yeah, it's not as drastic as most people assume. When the patient goes home from the hospital, they are in a fluid diet for a couple of weeks, and they upstate from there. They go to pureed diet.
So after surgery, they go on to liquid diet.
Exactly. So it's thick fluids essentially for the first little while everything heals. Within about a month, we see them in the office, and they're starting on some solid foods at that point.
Okay.
The general recommendations are that they eat multiple times per day, and they eat small amounts. And if you look at what they're eating at that point, it's generally a fairly overall normal, healthy diet. We encourage them to get protein at every meal, usually some solid protein, so they get that full sensation quite early. And there's usually a vegetable involved with that. But if you look at it, it's actually a fairly normal, healthy diet.
That's after third month, that probably.
Yeah, usually they're starting that food about a month after, and within a couple months they have a pretty set diet.
So that's like a small child feeding, starting, first liquid, then semi-solid, and then
essentially
solid.
Similar diet. That's right.
And then they come back to the normal, but the proportion has to be maintained probably.
Exactly. So they work very hard with our dietitians, and they get about a 5-year follow-up in the clinic there to make sure that they maintain these changes long term.
Right.
So essentially they're encouraged to eat at least 5 times, sometimes 6 times a day, very small meals, always with protein. We try to separate their liquids and solids because there can be issues with what we call dumping syndrome on occasion. But overall, if you look at what they're eating, it's actually a fairly normal diet.
Thank you, Dr. Cassie. We'll take a short break and we'll come back.
Thank you.
Thank you. Please stay back for the last part. Welcome back to the show Talk with Your Doc, and we have Dr. Scott Cassie with us. We are learning about bariatric surgeries from him. Dr. Cassie, you were mentioning about the changes in the diet required, and first we start with soft liquid diet, and then semi-solid diet, and then we have regular diet. Now, what are the other lifestyle changes needed after the surgery other than the diet?
Sure. The main things would be these patients are dependent on vitamins post-operatively, so a daily vitamin that's set out by our dietitians, and they have to make sure they religiously follow that. They do have to take some antacid pills for the first 6 months as well to prevent ulcers. Beyond that, of course, we encourage exercise on a daily basis to make sure we're helping to maximize weight loss and keep that weight off.
Right.
And those are really are the big changes. We do a lot of work through the dietitians with the patients on mindful eating, so being aware of why they're eating, why they're taking in what they are, and as well stress management. As you know, many of us will use food anytime we're stressed, and it's no different with our patients. And so there's a lot of work with that to avoid overeating for reasons other than hunger and nourishment.
Right. Now, you were mentioning about dumping syndrome. Can you please tell us something about this syndrome?
Sure. It's, I'd say, largely historical nowadays because we know enough about it. Typically, if you've had a gastric bypass or any form of gastric resection for a tumor, because of the reconstruction that we do, if you're eating foods that are high in sugars or really sweet foods, can evoke a fairly unpleasant response in terms of some cramping, discomfort. It can affect your blood sugar levels. It can be quite unpleasant. And so this is something that was a big problem in the past. Now there's so much education about it, and specifically in the clinic when they work with the dietitians, and there's so much education for the patients, we don't really hear much about it anymore. And patients will experience it once or twice, and they know which foods to avoid.
So which foods to be avoided after the surgery?
After the surgery, I mean, it's basically anything we consider unhealthy in normal life. But obviously the sweets, the high fat, high saturated fat, trans fats, those types of things. But the sugary foods are the big ones, and those are the ones that will give them the dumping syndrome.
So fruits, vegetables are really good.
For sure, exactly. Yeah, normal, high fiber, healthy diet.
Right. Now, after the surgery, with the change in the lifestyle and diet and exercise, what are the changes in the physical appearance of the patient, and how does he cope up with those things?
Sure. There is always some issues with some hair loss, and the amount varies between patients, and usually it does slow down. It can be a bit stressful on some patients up front, but it usually does slow down. It's not a long-term problem. There can be some changes in temperature regulation on occasion if they're having very quick weight loss. And then the biggest thing, obviously, as they lose weight, there will be some excess skin. and it's difficult to predict what areas will be affected. Certainly the panis or the belly is the most common.
So it becomes loose skin.
Exactly, loose skin, and it can become a bit of a hindrance for them. And so we do have patients who seek out plastic surgery. We usually tell them to wait at least a year or two post-op so they've maximized that weight loss.
Right.
And on occasion, there are even patients who want other areas of the body, say the arms and legs, and get what we call body contouring surgery. And we're fortunate enough to have that offered here now with our plastic surgery department, is able to do that here in the city as well.
So are all these surgeries covered by the insurance or OHIP? Or?
Sure. So the bariatric surgeries are. So anything, as long as you meet those criteria that we talked about earlier, then you're a potential candidate, and anything that's done here in Ontario is covered by OHIP.
Okay.
There are some out-of-pocket costs for the patient in terms of the weight loss shakes beforehand, and in terms of the vitamins afterwards. You need to make sure the patient can afford that, but the operation itself is covered. In terms of the body contouring and what we call the paniculectomy, that's an area I can't comment on as much, but most of that, from my understanding, is more out-of-pocket cost.
Okay.
If the paniculectomy is deemed to be medically necessary by the plastic surgeon, then there is coverage available.
Covered, right. Now, how about the support from the family, social support, social relationship? What is the impact of that on the surgery?
Sure. I mean, that's a profound impact. For most patients, we find if they have strong relationships going in, those relationships don't change post-operatively. It's a huge support for these patients, and we do find there's a nice network of patients online right now that from the area who all work together, and so they all have social support amongst themselves for sure, but amongst family as well. It can be difficult for them for sure in some cases. So this is something that attracts a lot of attention when they're losing weight, and it may be attention they're not used to, and so they do work with our psychologists to make sure that they can adapt to this and adapt to the new attention that they encounter from the weight loss itself. And as well, although most of the experiences are very positive, you have to be aware that their social network, some of those individuals may be obese as well. And so occasionally there may be some negative impacts in terms of if a loved one or a partner is not experiencing the same weight loss and the same success, there can be some hard feelings, and it may be difficult for them as well. And so that's why we have psychologists and social workers in our clinic who are available to deal with these patients post-operatively if necessary.
Right. Now, after the surgery, if there is a very good amount of weight loss and there is a change in the external appearance, how is the change in the confidence level of the person who is undergoing this surgery?
Sure. In general, it's very profound, and that's one of the most satisfying aspects of the job, to be honest with you. To be honest, it really depends on the individual. Their weight doesn't really bother them preoperatively, they just want to lose weight to be healthier. But there are certain individuals who are very negatively impacted, either for social reasons or even physical reasons. Their weight actually limits them from doing certain activities. And for some of these patients, when they come back a year later, and some of them, I just ran into a patient the other day who's now competitive in CrossFit, and she's lost half her body weight and is doing tremendously well. And most times the patients eventually at some point during the course of follow-up will tell us that they have their life back. They're doing activities they haven't done in years. They're doing things they dreamed of doing in the past and they've never been able to. And so it's a very gratifying aspect of the procedure.
Huge boost in the self-confidence probably.
For sure, no question at all. Yeah.
Now, to reach up to the stage of bariatric surgery, one has to go through the family doctor, and what is the steps involved in all this surgery? Yeah,
so in general, at least here in Canada, it's a referral process. So the family doctor, any primary care physician, nurse practitioner can make a referral. Everything is done online. So the OBN, or the Ontario Bariatric Network, has an online portal. The family doctors go on there, they make a referral process through there. It's all centrally analyzed and sent back to our clinic. And anybody who fits those criteria we talked about is at least assessed. It's a multi-step process. So they start by seeing an internist in the clinic to make sure there's no other medical issues that need to be sorted out. They see a dietitian, a social worker, they see a psychologist, and basically everybody has to be on board and say this patient is a good candidate, and all concerns have been taken care of before they get to see us in the office.
So how long that takes about?
In general, overall, it's a few months. Usually by the time they see us, it's probably another few months until an operation.
5 to 6 months probably?
Probably on average, yeah. If there's any concerns raised at any of those points, they may spend a few weeks or a few months working with that individual to make sure that those concerns are alleviated and everything's
Right.
taken care of before they pass them on to the next level.
And how long they have to stay in the hospital after the surgery?
Usually 2 days. So
2
on
days.
post-operative day 2, we let them out of the hospital, assuming all their blood work and vitals are normal.
Normal.
If they're from more than an hour away from the city, we ask them to remain in the city for a week afterwards, because
Mhm.
that's that concerning period for leaks and blood clots.
Mhm.
And they check in with the clinic on post-op day 7. If everything looks good, they're allowed to go home at that point, and then we see them 1 month post-op in the office.
Okay, and then they are followed with a dietitian and
Yeah,
psychologist.
exactly. So they get long-term follow-up for full 5 years after that.
Great. Thank you, Dr. Cassie. You gave us a lot of good information about the bariatric surgery. Really appreciate your help.
Well, thanks very much.
Thank you.
Appreciate it.
Thank you for joining for the show. Talk with your doc. See you for the next show.